All right, so we are recording tonight, so just so that you know, and that means that the recording will be available, in a few days or what have you, in case you want to show it to anybody else or share it around. So the first thing I'll say is thank you to Stronger, who's co-hosting the event tonight with us. Hopefully there's some people who heard about the event through them. They're also an organization concerned with the role of communication and social media communication in health science and tech, and all about literacy and understanding these issues. They're a campaign that informs the public about health misinformation and serves as a conduit for people to support local pro-vaccination organizations, and also teaching audiences how to shut down misinformation. So they're a great organization to check out. I'll post their information in the chat box in a second. And for those of you who don't know, the other host organization is One Day Sooner. We were founded earlier this year to advocate for human challenge trial volunteers. So we're all about getting a vaccine more quickly to end this crisis and the COVID crisis as quickly as possible and save lives that way. But we're also very concerned with the whole vaccine development process and the distribution process happening more justly and equitably. We're concerned with that both domestically and abroad. And so we've started hosting these conversations. We had one earlier in the fall, and we'll have a couple more coming up as well, digging into some of these issues and realizing and recognizing that race and racism come up at every facet of American society and of the vaccine process. So it comes up everywhere from medical research, obviously the impact of the disease to begin with. It comes up in communication around the disease. It comes up in distribution of a vaccine in all of these places. So we're trying to have sort of as many conversations as possible, raising as many issues, and hoping that can guide our efforts as we go forward, both with advocating for challenge trials and then also in the broader, the broader scene of both the COVID crisis and sort of medical research as well. As I said, this racism, and justice are embedded everywhere in our society and in these systems. Obviously, we started hearing pretty early on that Black, Latinx, and Indigenous Americans especially were being disproportionately affected. We've also heard more and more news stories on the need for diversity and participation in clinical trials for a vaccine. And there's also increasingly talk about vaccine hesitancy. That sort of started out in this place of worrying about anti-vaxxers, worrying that those people were going to sort of start this larger conversation and make vaccination, slow it down among sort of the public at large. There's also this partisan divide that has come up more and more recently as these more and more polls come out that have often very specific questions. Those numbers of who's willing to take a vaccine right now have gone down, and we see a partisan divide there. And there's also more and more awareness of hesitance among African Americans, among Latinx people, immigrants especially, and also, and among other non-white populations. The Kaiser Family Foundation came out with a poll last week or the week before with the Undefeated, saying half of Black adults would probably or definitely take a safe and free vaccine, or I should say only half. That compares with 60% they use Hispanic as their designation, and 65% of whites who definitely or probably would take a vaccine. And so health communication, which is what our panelists here, health communication, public health, are talking about today, is by no means limited to vaccines and vaccine hesitancy. That's certainly just a starting point, and I'm sure this will go beyond that. But obviously vaccination is one of the big issues that we're facing coming up next. And we want, again, we want to start this conversation about how that particular aspect of this can be more equitable, how it can be an opportunity to start fighting for, bringing justice into these conversations and not just doing things sort of the way they've always been done. So on this panel, we have two social media and communication scholars who I'll introduce in a second, and two public health scholars. They all are thinking about communication in a variety of ways, and a variety of interesting ways. All of them are young graduate students, recent graduates. So I think they'll be bringing fresh perspectives and helping us think through these issues in ways that are both establish the work that they're building on, and then also the work that they're doing that is sort of pushing us in new directions. The questions that I've posed to them, they'll talk about their research And I've posed these two questions to them of what needs to happen right now and what role vaccination can play right now in creating a more just health system and creating a more just resolution to the COVID crisis. And then also what needs to happen long term. It's super important to recognize that nothing that happens right now is going to solve the things that have been going on in this country and in this world for hundreds of years. So hopefully we can also think about where this needs to go in a larger sense. So I'll introduce the panelists, and then they'll each have a chance to talk for about 10 minutes. And then we'll open it up to Q&A, first among the panelists and then at large. Chioma Woko is a doctoral candidate conducting health communication and social network research at the University of Pennsylvania. She studies how new media can be used to address racial health inequities by encouraging adoption of health promotion behaviors. And she is focusing on persuasive messaging efforts and how they can mitigate the disproportionate effects of the COVID-19 crisis. So I think she's very much at the cutting edge here of really dedicating her research to this moment. She's also a recipient of the Robert Wood Johnson Foundation's Health Policy Research Scholars Fellowship. Yonaira Rivera is an assistant professor of communication at Rutgers in the School of Communication Information. Her research focuses on reducing health disparities and improving the well-being of Latinx and underserved communities through health communication initiatives. And she finished her PhD in social and behavioral sciences at Johns Hopkins. Nambi Ndugga is a graduate of the Chan School of Public Health at Harvard and is currently a policy analyst at Boston University in the School of Public Health. She is a staunch advocate for centering human rights and social justice in the field of public health. She's written about race and health in a variety of places, which I think are linked to or mentioned on the Eventbrite page. And Keona Wynn is a doctoral candidate in population health sciences at Harvard. She studies race, bioethics, and the moral factors that prevent populations from being healthy. She has a master's in bioethics from Harvard, where she is a senior equity, diversity, and inclusion fellow. She's also a Robert Wood Johnson Health Policy Scholar. And Keona and Nambi also have started a project. They started this over the summer called Public Health Care Packages to distribute resources, things like face masks, water, hand sanitizer, business cards for lawyers to protesters. So they started this around the George Floyd protests, and they've continued putting together these care packages in a way that bridges their academic work and their community engagement work. So I wanted to mention that because that's another big part of this communication conversation and how it can happen both online and in social media, and then also in other kinds of spaces. So with that, I will hand it over to Chioma. She can get started and then we'll go from there.
Thank you, Mabel, for that introduction. My name is Chioma Woko, and as Mabel said, I am a doctoral student at the University of Pennsylvania, studying health communication and broadly how social media and social technologies can be used for health promotion among Black populations. And my dissertation will be focusing on vaccine hesitancy, COVID-19 vaccine hesitancy among African Americans, beliefs driving resistance, and how we can use that information to develop persuasive messaging campaigns to encourage support for vaccination. So today I want to just talk about how anti-vaccination and vaccine hesitancy beliefs relate to media use and specifically to social media use. So vaccination has been extremely successful as a public health intervention and as a tool for communicable disease infection control. But for vaccines to work, there needs to be public support so that the required proportion of the population can receive them in order to enable society to approach herd immunity. However, we don't often have this population-wide support for vaccination, which has led the World Health Organization to identify vaccine hesitancy, which they've defined as the delay in acceptance or refusal of vaccines, despite availability of vaccine services, as one of the top 10 threats to global health. The media sources we engage with have a relationship with vaccine-resistant sentiments, as well as other health-related beliefs. We are exposed to health information in mass media that is both true and untrue, which shape the beliefs we have about health topics and can ultimately affect our behavior. And when it comes to social media in particular, The potential effects of exposure to health information on these platforms pose concern to public health because of a lack of editorial regulation and the inability to vet the accuracy of the information that is disseminated on them. And this concern becomes particularly important because of the disproportionate consequences exposure to false health information can have on populations experiencing health inequities. Decades of public health research has established that there is inequitable access to healthcare resources experienced by Black, Latinx, and Indigenous communities in the United States. For example, these demographics are less likely to be insured, tend to have more physical barriers, accessing healthcare facilities for affordable care, and the quality of care they receive from providers is not the same compared to whites. These barriers are directly caused by structural racism, which affects our healthcare system along with other infrastructures. And ultimately, not having equitable access to healthcare resources also impacts the quality of health information people have access to. In addition, because of the legacy of exploitation and mistreatment Black Americans have and continue to experience at the hands of the healthcare system, trust in the system as well as information from it has been degraded. And this combination of a lack of access and a lack of trust in part explain why people seek out health information from other sources. So partly because of this lack of trust and lack of access, members of marginalized populations are more likely to seek out and trust health information from their social contacts, including on social media. And this poses concern in the public health community because on social media, people are more likely to find themselves in echo chambers, meaning that they're connected to others who share the same viewpoints and biases as they do. Social media allows people to connect with others they might not have been able to without it, and it provides us with unbridled access to all sorts of information, which is an important benefit of their use. However, these same advantages make these sites fertile grounds for the dissemination and exposure to health misinformation, which can be associated with behavior. Anti-vaccination sentiments are an important example of this phenomenon. For example, a recent study found that there was an increase in anti-vaccination content from 2014 to 2015 on social media that coincided with a measles outbreak that occurred in that time frame due to a decrease in MMR vaccination rates. So as we dive into addressing COVID-19 vaccine hesitancy among African Americans, we must take into consideration how social media content might be contributing to it. Essentially, the public health field should be concerned about unverified information about COVID-19 vaccination influencing beliefs related to vaccination, because of course, for Black Americans, we're talking about a demographic that has been disproportionately impacted by the pandemic. As we go about strategizing for allocation and planning to address vaccine hesitancy in this population, we must not discount or trivialize the valid concerns people have about forthcoming vaccines. Because vaccine hesitancy is something that is really complex. It is context specific to the particular disease area, and it is influenced by a variety of concerns. Researchers should be sensitive to the lived experiences, the shared anecdotes, the cultural factors, and the historical context that are likely to be driving resistance. Such factors have also come up as barriers to vaccine acceptance for African Americans against the flu, for example, and it is likely that they will remain relevant in the context of COVID. So as the public health field continues to plan for equitable allocation of COVID-19 vaccines, the interacting consequences of these previously mentioned equity issues must be taken into account. Specifically, the disproportionate impact of the pandemic on African Americans is one. Second, the demographically specific drivers of COVID vaccine hesitancy. And third, how social media can exacerbate the effects of health inequity through facilitating exposure to false information. Our next steps should involve efforts to debunk misinformation, data collection to understand beliefs behind vaccine hesitancy for the most at-risk groups from social media as well as other sources, and leveraging existing relationships different service providing organizations have with the more at-risk and harder to reach subgroups. And Mabel, you asked us to talk about what we think are short-term actions that we can take to center and pursue an equitable solution to this crisis. So one of the first things we can do is, I'm going to propose 3 things. And the first of them is investing resources in misinformation campaigns that address misinformed beliefs that also emphasize transparency and uncertainty. The misinformation that is circulating on social media and other media sources might be influencing people's beliefs about COVID-19 vaccination, whether or not people believe that they have endorsed these items of misinformation. And specifically, the demographic that we want to accept vaccination should be the people that we target. So we need to invest resources in debunking these messages. But in doing so, we need to clearly communicate that there's a lot that we will not know when one or more vaccine candidates become available. For example, we will not know how these vaccines will affect the entire population, especially those that are most at risk, because currently in clinical trials right now, people that are participating are not the people that are the highest risk of severe morbidity or mortality from COVID-19. We're not sure what the supply will be, and also comparative rates of efficacy is still going to be uncertain. So doing this, communicating what we don't know while also emphasizing the benefits of vaccination generally can be a way that the healthcare system and public health can help fix that trust that's been degraded on the part of African-American populations, Latinx populations, and other populations that have experienced a legacy of exploitation and have reduced trust in the American healthcare system. The second thing that I think we should do is we need more investment in collection of data, both online and offline, and specifically on social media and on other sources. Social media data collection can provide us with a lot of information on generally what people are thinking and talking about when it comes to vaccine hesitancy. And sites like Twitter are very fertile ground for social scientists when it comes to collecting information on what the population is thinking about. But it's important to note that we're not going to be able to understand what the most vulnerable and at-risk groups are thinking about, what their drivers of concern are using social media. So also investing resources and time into collecting data from other sources. And that leads into my third point. Because social media users, especially a site like Twitter, where only about 24% of American adults are users, and the users are so much more different from the general American population. They tend to be younger, they tend to be more well-educated, make more money. So the subgroups that are being proposed to be prioritized for access to the vaccine early are people that may not be using these sites, and then we cannot understand or learn what their concerns are from a site like Twitter. So essentially what we should do is leverage already existing relationships and partnerships, organizations that are providing services to these most at-risk subgroups have. For example, the National Academy of Sciences recently released their framework for equitable allocation. And in that, they laid out phases within which they have categorized groups of people who are at the highest risk of infection and severe morbidity or mortality. And among those in the earlier phases are frontline health workers, elderly, people living in assisted living facilities, people that are experiencing homelessness, people that are incarcerated. So there are organizations, for example, working with the homeless population that will be better able to connect with them and interview them and learn what their concerns might be. And that would be a more fruitful way to engage with populations like that, rather than spending a lot of time trying to collect data on social media that might not be applicable to everyone. So I think doing these three things in tandem this is a way that we can, in this moment, center and pursue equity in our response to this particular issue of vaccine hesitancy.
Great, thank you so much. Yonaira, do you want to talk next?
Absolutely. It is great to be here. Thank you so much for the invitation. I'm thrilled to finally be with all these amazing panelists. And I am actually going to start by talking a little bit about the work that I have done in the past, particularly related to cancer, misinformation. A lot of the work that I've done is in cancer, and then kind of bring in COVID and talk about the Latino community and address your questions, which I think are incredibly important. So I completed my dissertation earlier this year, and my area of focus really is understanding how engagement with health misinformation in general, but particularly cancer-related misinformation is acted upon among Latinos that use Facebook in particular. So a little bit of background on the Latino community and cancer. It is a leading cause of death, and it's really important that as you mentioned, Mabel, I did my degree in public health, so I'm very immersed also in the area of public health, and it's really important for us to be delivering health communication through different ways and platforms where audiences are. And the Latino community uses social media a lot, particularly Facebook is very, very popular with the Latino audience, as well as WhatsApp. And I'll talk a little bit more about WhatsApp later. So as we engage with audiences to educate them about different areas of health, it's important that we also understand what it is that they're engaging with, what it is that they're consuming on their platform. So that was kind of where I was going with this research. And I specifically was looking to understand how Latinos of screening age for breast, colorectal, and prostate cancer, so 40 to 75-year-olds, are engaging and assessing the credibility of the cancer prevention and screening information that they're consuming on these platforms, and what they are doing with that information, if anything at all. So among the findings that I saw that were very interesting is that many people were engaging with content that was shared by people in their network, right? It wasn't necessarily evidence-based content, but it was shared by people that they found trustworthy, kind of assimilating to what Chioma was saying, but also what the literature says, right? The source of the information is a very important factor, and trust is a huge factor in those relationships. And another thing that I found that was very interesting is that cultural values and other cultural connectors, such as language or country of origin, were very important and played a really important role in how message factors and source factors influenced engagement with cancer misinformation on these platforms, and also how people assess the credibility of the information. So people tended to engage with content that was maybe of a similar language. So if they preferred to speak Spanish, content that was in Spanish was very popular. Content that had images of different fruit or foods that are commonly associated with having cancer prevention properties. And then that kind of elicited conversations about experiences and personal stories that have been shared from their family members and people that they trusted within their community. So really looking at how all of these cultural connections play a role in engagement and credibility assessments. But another thing that was really important is that a lot of people tended to use cognitive heuristics that were informed by these cultural values in assessing the credibility of the information. So even though we would hope that people are going and using a very cognitive process of verifying the information, they aren't necessarily doing that, and they're going by these cues that in many cases had to do with relationships that they had with the sources. So what was really important is that, and this really comes to light with what we're seeing with COVID, is even though it wasn't in every case, there were times where engagement with misinformation led to the uptake of behaviors that aren't necessarily evidence-based or what we're trying to promote. In the case of cancer, there was an example of a participant whom she was Puerto Rican. She saw a video of someone that she thought was a physician who was also Puerto Rican saying that mammograms cause breast cancer. So she called and she canceled her mammogram, right? So there was a very stark outcome related to her engaging with this content that was culturally relevant for her. Of course, so how does this kind of go with COVID? You know, we have been seeing a lot of stories of people that have been reading misinformation and making health decisions based on that information. But I think that one of the things that's really important for us to also bring to light, not only with the Latino community, but with all audiences, is that COVID has just uncovered a lot of these structural issues that have existed within this country for a really long time. And it has done so in an environment that has so much uncertainty, and there's a lot of speed with which we are disseminating information about this. And I don't think that the speed of the scientific process aligns with the speed of journalism and the speed of disseminating information on platforms like social media. And that has, I think, amplified the reaction that people have had and increased mistrust in agencies that traditionally we have trusted as a source of health information. The Centers for Disease Control and Prevention, et cetera. There have been so many different agencies that when you look at polls, mistrust has gone up. And that's very problematic because these are the sources of really important health information for a lot of these audiences. So another thing that I kind of want to highlight is that with COVID and social distancing, you had a lot of people, including the Latino community, relying on platforms like Facebook and WhatsApp to engage with their families, right? So we know that they already use these platforms. They're very important. They're a source of misinformation. And now that's been amplified. And you also have audiences that maybe don't have the digital literacy to be able to discern what is accurate, what is evidence-based, and what isn't. And I heard this a lot in my interviews and in people that I've spoken to. Well, I share this information with others just in case, right? I want to make sure that they have the information they need just in case, because there's so much uncertainty. We don't know what's happening. And I think that kind of gets to one of the things that I think that we need to be focusing on, as Chioma was saying, focusing on digital literacy, focusing on health literacy among these particular audiences. Now, in regards to the Latino community in COVID, a study recently published by Dr. Carlos Rodriguez-Diaz and his colleagues at GW highlighted the disparities that we have seen in the disproportionate number of Latinos that have had exposure to and died from COVID. I just want to pull straight from his discussion. One of the things that they highlighted is that in the US, Latino counties only account for 11% of counties in the Northeast, 4% in the Midwest, and 33% in the West. However, they comprise 63% of cases and 66% of deaths in the Northeast. 32% and 26% of deaths in the Midwest, and 75% of cases and 73% of deaths in the West, right? So we are seeing disproportionate numbers. And when we look at why, there are definitely several reasons. Not only Are we seeing that Latinos are younger? They also are employed in jobs that expose them to COVID at higher rates. In addition to that, we see a lot of monolingual families in these counties, and that also saw predominantly speaking Spanish or only speaking Spanish was also a factor in higher numbers of cases and deaths. And in addition to that, we can talk about things that we already know, right? Fear and mistrust in the system. There are a lot of Latinos and Latinx communities that are facing a very hostile environment right now, where they do not feel comfortable going to the doctor. They don't feel comfortable seeking healthcare. They might not even have access to those things. And those are very important things that we need to think about when we want to focus and target conversations about vaccines and vaccine uptake with this particular community. When you kind of look at the literature about vaccine barriers among the Latino community, it's kind of mixed. There's actually less vaccine hesitancy. Actually, Mabel, you were saying in one of your statistics that as well. And depending on the audience, right? Latinos are a very heterogeneous group. We're not homogeneous at all. So that's also very important for us to be considering when we think about health communication campaigns to target these audiences for vaccine uptake. But there's definitely less hesitancy with some HPV vaccines, the H1N1. There was a study that looked at uptake of the flu vaccine after H1N1 with the Latino community in Mexico, not in Mexico, I'm sorry, in California. And they were speaking about how they actually do trust the efficacy of vaccines and the safety of vaccines. But one thing that was very important is that there is a heavy paternalistic view of medicine within some Latin American countries, right? And those that are less accultured have more trust in the recommendations of a doctor if they have access to one. So I think that that is also something that we need to think about in terms of how do we educate and have conversations about vaccine uptake. And there's also, of course, some Latino communities around the US, depending on the area. Some are of lower income, and they also might be enrolled in vaccine for children programs and have access to vaccines like the HPV vaccine. So we also see less hesitancy in some of those communities. However, there's definitely literature supporting that there's fear in novelty. So this is a vaccine that is going to be responding to a huge environment of uncertainty around COVID, and we cannot disregard the politicization of all of these issues. So we need to be taking that into account when we also educate and communicate with these audiences about the benefits and why it's important for them to be vaccinating and participating in vaccines and vaccine efforts. And I think that's something that's important to also consider with the Latino community is that we tend to have collective worldviews. There are several cultural norms that are important and embraced by a myriad of Latino audiences. I don't think that they are exclusive to Latino audiences, but they are important to us. So it's important that we use culturally appropriate messaging and culturally sensitive conversations and topics when we're developing these campaigns and efforts. And I finally also wanted to bring up clinical trials very briefly. Mabel, you were talking about the importance of this, and depending on the literature and the area, you will see that Latino numbers for clinical trial enrollments go from like 1% to 5%. I do work in cancer, as I mentioned, so depending again on the type of cancer, regardless, it's still very low, right? So it's important that we are also targeting our education to these areas. And there's definitely literature from Quinn and other researchers at Moffitt Cancer Center that have focused on the uptake of Latinos in clinical trials and cancer trials. And the importance of family is huge. it's important to incorporate families in communication about clinical trial participation, because participants tend to share that information with their families to make an informed decision together when they are going through the informed consent process. So in terms of your final questions, in regards to what we can do immediately to have a more equitable resolution to this crisis, the first thing that we can do is vote, because these things are instrumentally linked to policies, and not just elections at the national level, but at the local level. This is instrumental, because as the statistics from this COVID study say, and our knowledge from a myriad of other issues that impact the Latino community, they are related to structural barriers. And we cannot put the emphasis only on the individual. So I think that voting is a very important thing. But another thing that we need to do, kind of going off of what Chioma was saying, is we have to be very honest in our communication. We need to be able to, as the scientific community, say to our audiences, there are things we do not know yet. We are still figuring things out. This is what we do know. Because the erosion of trust in the scientific community is the biggest detriment to us trying to address misinformation, vaccine hesitancy, COVID related issues, etc. It's so important that we establish and maintain that trust. And one of the ways that we can do that, based on my work and the literature, we really need to be engaging with community leaders. We need to have established relationships with communities, opinion leaders, faith-based organizations, health educators that are known within the community, to have them convey our message. That can be done in this time through social media. We see people on social media. We see these audiences on social media. There are a lot of entities, grassroots organizations in the Latino community that use these platforms to engage directly with their audiences. Some of the other work that I do looks at disaster relief work in Puerto Rico. And social media has been instrumental in us working with community leaders to establish trust as researchers that are coming to the community to help them with issues that they're facing. So that is instrumental. And then long-term, I would say that getting to the conversation of structures, not just at policy in regards to our interactions offline, but we need policies that are regulating content on social media. We need policies that are structured, that are really dealing with the fact that as individuals, we can only do so much when we have algorithms that are promulgating certain type of content, that are just making these echo chambers continue to exist. And we're seeing the ramifications of health misinformation literally leading to death. So this issue has only highlighted social determinants of health and social inequities as root causes of disease in this country. And we really need to push harder as a scientific community against for regulatory policies for these platforms.
Great, thank you so much. Keona, do you want to talk a little bit next?
Hi, Mabel. Hi, everyone. Thank you for introducing me. So my name is Keona. I'm a public health scholar at Harvard-Chan. And so I'm still in graduate school, and I'm starting to think a lot about this interface of race, ethics, philosophy, public health, psychology, kind of trying to bring it all together. And so I actually think it might be the most valuable if I start at the end and then go back to the beginning, because I realized that I might have got really in the weeds towards the end. So it just might not make sense. And so I think that there's this larger conversation that's occurring on personal responsibility for health. And I think that conversation is happening in regards to mask wearing, is happening in regards to vaccination hesitancy. And so there's this phenomenon that's happening in regards to like the images that we see. And so I think that we can use the images that we see and on social media to go beyond, well, in particular in Black community context, just wearing a mask or not anti-vaccination, but vaccination, to think about what are the images that we're seeing of Black people. Can Black people be caring? Can Black people exist peacefully? And I like to think of it, a term that I'm starting to use is empowered caring, where we are caring for our neighbors and we're caring for ourselves. And so that's very much along the messaging of mask wearing and vaccinations. But I think where it gets particularly profound is that Black bodies are typically seen as violent, as harmful. And so whenever we can say that Black bodies are caring and capable of empowered caring, I think that we can really move forward a lot of our health messaging, and we can really start to alter health behaviors. And so now I'll go back to the beginning, but I wanted to make that point clear that that's what I like to think about and what I'm trying to start to think about. So every time I speak about like the impact of race and racism, I like to just recenter us in what's at stake here. So as of 2019, the US Census said that Black Americans are estimated to be up to 14.6 of the US population, which is 48 million plus people. So we're talking about an incredible amount of people. And I like to bring that back because sometimes whenever we think about a minority population, we tend to think small numbers because minority just brings to mind a smaller number, but we're actually talking about an incredible amount of people. So there is a lot at risk. And so we've seen all of these arguments start to be developed around, should Black Americans be prioritized for the COVID-19 vaccine first, due to the disproportionate impact along with Latinx and Indigenous communities. And I think that we're going to see those arguments come to light more, but I do believe the two panelists who spoke before me did a great job at talking about the misinformation and the trust and those barriers and bridges that's going to have to be overcome. And so I want to start and to shift and to think about, well, what can it look like whenever we start to try and distribute vaccines, and how can social media play a role? And so I step back and I think, well, how is social media already playing a role? And so social media is this powerful tool for spreading images of caring and violence. So we see all the time images of violence against Black bodies on social media. You see videos of Black people being brutally murdered. You see, images of Black people being quote unquote thugs or gangsters, or all of these things that invokes violence towards yourself, towards your community, towards your greater neighborhood. And so we see all of these images of violence. And I think this tweet, getting to what Chioma was saying about, like, we need to think about social media also as a data collection tool. There was this viral tweet that happened after George Floyd's death, and it reads, "Being Black is having a good day, and then seeing another Black person was killed for no reason. Then you have to talk about that all day, or don't, and numb yourself. It's a constant emotional war." And this was tweeted by Quinta Bronson. And so this gets to the heart of what I like to think about with my research. Whenever people, a culture, or an individual is construed as violent, as hostile, as dangerous, there is this internal emotional war that happens, as as Quinta states, or, this disconnect from the self, where a person is not able to integrate these experiences into their lived narrative because either a fear of the self or just not having the emotional capacity to process it. And so if we're only seeing those images of Black people as violent, then I like to think about, well, what does that mean when I go to care for myself? If I only think of myself and my community as violent, then where does caring fit in? Because I like to think that health and seeking out health opportunities and endeavors is an act of caring for yourself. And so I do like to think about that flip a lot in that flip actually really became evident to me in some of my community engaged work. And so, as Mabel mentioned, Nambi and I started a initiative called Public Healthcare Packages over the summer, where we were able to go out and give packages to Black Lives Matter protesters. And one thing that I did, Nambi did a lot of the administrative work. So I'm not sure she's going to talk about that, but she was phenomenal. Can't sing her praises enough. And I got to do a lot of the on the ground work. And so one thing that I really enjoyed doing was giving these packages to the local population, the local homeless population with high rates of substance abuse. And so during one of these times of giving these packages to an individual, I also was able to give a few extra masks. And what happened really stuck with me. This person immediately started to cry and said, "Wow, you care enough about me that you just want me to live for the rest of the week." And that moment really, really resonated with me, because I thought, wow, I just never thought about it in that sense, that I'm just caring about you, that the act of caring in itself is so profound. Is showing care and giving care, and being able to know that you are a caring person and that you are deserving of receiving care. And so this was still resonating for me throughout my time giving care packages. I was able to gather a broad coalition of public health workers, of community workers, of community, just local community members. And most of them were Black Americans. And we would have Black men and Black women shouting into the crowd, "I love you, I care about you, I want you to get home safely, please take this mask, please take this attorney's lawyer number, please do this, like, I care about you," at a time when people were literally protesting for their right to life. And I paused and I saw how profound that was, because so many people are unexposed to images of Black people as caring, when you're only ever seeing Black people as violent, or Black people as activists, or something along that lines, but never just Black people as genuinely caring humans. Then I had to pause and say, well, what does that do to, like, the imagination to care, to give equally and reciprocally? And so that moment was really foundational for me to begin to kind of center the importance of what are the images being circulated around Blackness and what's capable of a Black experience in the United States of America. So coming back to this idea of how can social media be a tool for vaccine distribution? I think it's important that we think about, well, what narratives and images are we centering around Blackness whenever we think about changing this idea of misinformation and changing this idea of trust? You know, is it one where we're seeing Black people as caring? And this brings me back to where I started. How can we say that this empowered caring? Because what we want to, or the messaging that I want to convey whenever we embark on this vaccination, is that I'm getting this vaccine to care for myself and to care for my neighbors. But I think it can be a lot more powerful than that. I think it can also be a moment where we say, and Black people are caring individuals, are loving individuals, and change this narrative that we're only seeing Black people as they're dying, Black people as hostile, Black people as violent. So I think this responsibility conversation can be even more profound and even more meaningful whenever we think about how can we change the images that we're seeing on social media.
Thank you so much for that. All right, Nambi, you're the last one up.
Hi, everyone. I hope you guys are all well, and thank you so much for inviting me to be a part of this panel. And thank you so much for Mabel and the other participants for tackling such an important topic. So I'm not sure what else to add. I think all the other panelists covered everything that we need to talk about. So I guess what I'm gonna do is talk a little bit about it from a global perspective. So prior to my work as a policy analyst, I studied global health and population at Chan with a strong focus on sub-Saharan Africa, and did a lot of work in Kenya, Somaliland, and other global South countries. And my work was promoting and implementing sexual and reproductive health and rights and maternal child health programs in those areas. And one thing I came to notice during my time abroad and my time in the US is that the impacts of political economy on health and health outcomes are similar among global South countries such as Kenya, South Africa, all these places, and global South communities in the United States. So Latinx communities here, African American communities here, Native American communities, et cetera. And what this means is that when you look within global North countries, these marginalized populations tend to have poorer health outcomes, lower access to quality healthcare services, and suffer from health inequities. And when you open your lens and look at it from a global scale, global South countries tend to suffer from those same inequities that are seen in these marginalized populations. And all of this tends to be as a result of imperialism and colonialism, which you can see as corollaries to sort of slavery and other atrocities that happen in the United States and have now had these major downstream effects that significantly have adverse impacts on these populations' lives. So going back to a global scale, so I tend to talk in like large and then small and large again. Going back to this larger scale, what we end up seeing is that on a global scale, in the global North, we have this concentration of power. So what this looks like is all the pharmaceutical companies, all the manufacturing companies, decision-making bodies, academic institutions, media institutions, social media powerhouses are all housed in the global North and not in the global South. So when we end up having these major issues, these major disasters happening on a global scale, pandemics such as COVID-19, natural disasters, other public health crises, these communities are left to fend for themselves. They can't compete on the same level as global North countries to get access to these medical resources, to these facilities, to these physicians, these doctors that they need at the scale that they need, which is a similar problem you find in global North countries when you look at these marginalized communities. The majority of academic institutions, the majority of high quality healthcare services are just not located in underserved communities, hence why they're called underserved, right? So one specific area where we saw this happening on a pandemic scale is during the 2004 H5N1 outbreak and the 2009 H1N1 pandemic. So what ended up happening was during that time, there was a global supply of vaccinations, but there weren't any policies in place to ensure there was an equitable distribution of it. So what ended up happening was global North countries bought out the entire supply of vaccinations. So global South countries couldn't afford any of them. So countries such as Indonesia and other places who had been hard hit by these pandemics weren't able to vaccinate their populations. And this led to, of course, there's a big scandal about it, but nothing would have happened if there hadn't been this major solidarity across global South communities in the world, right? Who came together and put pressure on the WHO and global North countries to talk about the fact that a lot of these global South countries have been exploited historically through imperialism and colonialism and continue to be exploited for medical goods. So a lot of the testing for vaccinations tends to happen in global South countries. And then during that same time, while they are providing material for the development of these vaccinations, they don't get access to these vaccines. So this led the development of these international bodies such as PIPFA, which stands for the Pandemic Influenza Preparedness Framework, and other international bodies that were put in place to ensure that there was an equitable distribution of vaccines and an equitable framework to preparing for pandemics. So flash forward to 2020, we're in COVID-19, it's happening, and we think we have these frameworks set in place to ensure that when we do have a pandemic, there's going to be an equitable approach to it, making sure that we're addressing past atrocities and ensuring that countries that can't compete with the global North on a market scale are able to access vaccinations and are able to access PPE and other medical equipment at the same level as global North countries. Those frameworks don't go into place. And a lot of global North countries, what they do is then implement protectionist policies or start closing down their manufacturing and distribution lines. So as I mentioned before, the concentration of these manufacturing bodies are in the global North. the global South is reliant on these other countries to ensure that they have the same amount of supplies to support their populations. So at the start of the pandemic, there was this huge fear that because global South countries didn't have access to enough hospital beds, to enough PPE, there weren't as many physicians spread out across the country, that there was going to be this huge influx of COVID-19 cases coming out of these areas. So far, knock on wood, it hasn't, while there has been a large number of deaths and infections due to COVID-19, it hasn't reached the predictions that a lot of public health experts had predicted at the start of the pandemic. And this is due to a number of factors. A lot of people are talking about the young age of the population, specifically in sub-Saharan Africa, and a lot of past experience with dealing with other pandemics, such as epidemics, such as Ebola and other diseases as well. But all this to say that the struggle for equitable distribution of vaccinations and equitable responses to pandemics cannot be looked at just a national lens. It has to be looked at an international lens. What's happening within marginalized populations in the United States and other global North countries is mimicked in other parts of the world when you span it out onto a global scale. And this is due to similar atrocities of imperialism, colonialism, race-based medicine, eugenics programs that came out in the early 1900s that have had far-reaching impacts on populations today. So other areas where you can look at that is just one other example is looking at the distribution of physicians in the United States, look at the distribution of physicians globally, right? So we've talked a lot about the lack of information, the lack of information, misinformation, disinformation going into these communities. And one major factor there is that there's just a lack of healthcare professionals, or there's a lack of linkages between major institutions and those local communities within the United States, and on a global scale within Black and Brown communities and their hospitals or larger healthcare bodies, right? And part of these issues are within the United States. In the early 1900s, the Flexner Report came out, which shut down a majority of African-American hospitals, right? Which means there's been a significant decrease in Black physicians in the United States. And therefore, there just aren't as many physicians who are working within the Black communities in the United States. And the few that are there tend to go into these communities to work there, but they're not enough. We're in a physician shortage. So how the United States has chosen to fill that gap is through importing or almost importing physicians from abroad. A lot of physicians come in from global South countries to fill these gaps. And when you look at the numbers, you see that, or you look at the census, you look at the medical numbers, a lot of physicians who are working in marginalized communities in the United States are from the Caribbean, are from South Asia, Southeast Asia, are from the sub-Saharan African continent, right? And this is all contributing to a major brain drain in Africa, in the Caribbean, and all these other places. So there's this big cyclical problem that's happening where because of poor policies, because of these historical injustices in the United States and globally, these populations are leaving healthcare opportunities within their countries, coming in to fill these gaps in the United States, yet minority population in the United States don't have the same opportunities to be physicians in this area due to a plethora of reasons. So when we are looking at these issues, we have to look at these in this global sense because it's all tied in together. And then we're coming up with solutions with regards to combating misinformation, disinformation, making sure that we have connections between legitimate sources of science, public health. We have to look at it at this global scale of what we're doing here has impacts on what is going on in other parts of the world as well. Which brings in, I guess, social media, which has been a really great tool that's been used to help bridge these gaps. Things that are really cool that are happening right now is you see a lot of physicians and public healthcare professionals, not just in the United States, but in sub-Saharan Africa, in Latin America, in Southeast Asia, and South Asia, using tools like TikTok, where it isn't banned, to, you know, showcase fun ways of, you know, like wearing masks, or like what you need to do, what does 6 feet look like standing apart from each other, right? And spreading this message, these public health messaging through ways that can reach far-reaching audiences. This has had a major impact of distributing public health knowledge in these places, specifically Sub-Saharan Africa. That's the context that I'm most familiar with, because they have a far-reaching mobile phone system. So a lot of people are able to, if they're in the village, in the cities, are able to get information through their cell phones. So through social media, Facebook, TikTok, Twitter, this is a way that public health professionals and physicians are using these tools. And I believe that we, as in the United States, can look at what they're doing down in those countries and apply it here. See what the concerns are within marginalized populations in the United States, understand what is a culturally sensitive, what is a culturally appropriate way of reaching young people, middle-aged people, old people, other populations within the United States through social media and through lenses that will actually reach them. And I think to further that conversation as well is we'd have to have communications that, I was fortunate enough to be part of a conference last week put on by Equal Health that looked at the global equity and Pan-Africanism within the public health field. And having these spaces where professionals in public health, in social media, and all health communications can come together and exchange ideas and talk about strengths and weaknesses of communication that can be used for these, that can be used within these populations. So I guess I just jumped into like short solutions that can be short solutions to communicating information for COVID-19, but that's one way of doing it. So like having conferences, international conferences that public health professionals or other people can come together and discuss these solutions to health communications. And then tying in what Dr. Rivera said, what Chioma said, what Keona said as well, investing in social media communication, data collection, and something that was mentioned very briefly, the disaggregation of data. So something that hasn't happened for a lot of communities over here is that we tend to lump groups into these major categories that aren't reflective of their cultures, their ethnicities, where they come from. So looking, one major group that comes up fairly often is within the white population. We have Middle Eastern and North African Muslim individuals who are all categorized as white within the United States. Yet their experiences of health outcomes, racism, Islamophobia dramatically impact their health outcomes compared to their white population. So any information or data that we are collecting for that group is immediately, it doesn't count. It's not accurate and isn't reflective of that population. Within the Black population, we tend not to disaggregate between immigrants coming in and which parts of the, whether they're coming in, which parts of the diaspora they're coming in from, or they're coming in from the continent. And we know that immigration status has a profound impact on healthcare outcomes as well, and also has a different, immigrants coming from different places have different ways of interacting with healthcare systems and ways of addressing different health ailments or things that are coming up. As Dr. Rivera said, the Latinx population is incredibly diverse, and that includes Afro-Latinx people who tend to get lumped into the Black category, where they may be more, they may fit better into, you know, a hybrid category that would, you know, both address their Black heritage and their Latinx heritage too. So these are things that we need to do as well when we're looking at data with regards to social media or public health outcomes, to ensure that we are able to create solutions that accurately and effectively address the concerns that people have and are able to convey the information that we want to convey in a way that is effective. So for long-term solutions, I mentioned the Flexner report that happened in 1910 that reduced the number of public health, the number of Black medical students in the country, and effectively like reduce the number of Black physicians in the country by almost like 75%. We need to work to recruit and make sure that minority populations are able to enter these public health fields and medical fields, that there is more representation in those fields, and there are more people who understand how to interact with these different communities and make sure that these voices are heard and have a seat at this table. So that's one long-term solution that can be addressed. And on a more global scale, during COVID-19, there has been development of COVAX, which is a global initiative to ensure the equitable distribution of vaccinations. And this is a short-term and long-term goal. So Dr. Rivera mentioned voting, making sure you're talking to your representatives and making sure that they're pressuring the United States to join COVAX and ensure that we do have an equitable distribution of vaccinations across the world. And working as well with the WHO and other international organizations to ensure that when we do have vaccines being developed, that they are being distributed in an equitable way, that we're not looking at it through a purely national lens. Because as with pandemics, especially infectious diseases ones, we're only as strong as our weakest links. If one country goes down with COVID-19, it's spreading to the other countries and affects the rest of the world. So for us to adequately create a good COVID-19 vaccination response and to effectively combat the pandemic, we need to make sure that we are looking at equity from a global lens. Thank you.
That was great. You guys covered a lot of ground and you guys complemented each other really, really nicely. You flowed into one another in a really interesting way. So that was great. So at this point, I'll give the panelists a chance to ask questions to one another. And if anybody else has questions, feel free to put them in the chat. Or if you'd like to ask yourself out loud, feel free to raise your hand. All right, one question that came up that I think is relevant to both Nambi and Yonaira is the question about local policies in particular. So I think both of you guys can speak to policy questions about what policies will help public health, help global health as well. And so particularly for Yonaira, what local policies, but in general, what are your policy recommendations, or what would you like to see?
Yeah, that's a great question. As I was saying, I think that we definitely need to be, when we're thinking about social media, right? And that particular regard. Social media platforms have definitely benefited from, sorry, I'm just inventing words tonight. Benefited from very lax regulations in regards to them being not creators of content, but disseminators of content that's created by others. And I think that we are definitely seeing now the implications of not only that kind of misinformation that has detrimental outcomes, but also that if we think about big tobacco, self-regulation hasn't been very successful. And we need to be a part of those conversations about how regulatory initiatives need to be taking place in regards to ensuring that platforms are a place where our rights, of course, are protected, our freedom of speech, but at the same time, not all misinformation is created equal. And we're seeing that some misinformation has very detrimental outcomes. So I think that we need to be much more vocal, especially those of us in the public health realm of conversations and policy, in not just speaking about it from the sidelines, but being immersed in that. In regards to other policy, as you guys heard earlier, I'm from Puerto Rico originally. I'm from Puerto Rico, and there are huge disparities that we're seeing in the island right now that have been exacerbated by more than a century of policies that have made Puerto Rican citizens not have access to the same level of care and resources than people in the mainland US. So I think that, again, this gets to voting and being more involved from a grassroots level in identifying what structural issues need to be addressed, funding needs to go towards, to build stronger communities that have infrastructures that ensure that audiences have access to care, have equitable access to care, not just access to care. They have, structures. Thinking again of Puerto Rico, there's still ramifications of the hurricane. We just had money released for hurricane relief this year during an election year to address issues in the medical infrastructure. When we think about issues here in the US, as Nambi was saying, we need more physicians that understand the cultural context of underrepresented communities within the US, right? We need to make sure that we have pipelines to train individuals from our underrepresented groups to be a voice and educating and providing service and care. And that, from a policy level, is something we need to be investing more in science. We need to be investing more in these pipelines. So I think those are some of the things. And then lastly, and I'll let Nambi kind of jump in regards to health communication, local health departments have been very important in educating audiences about this pandemic. We need to be funding and working alongside these entities because every state, every local community has its own issues, and we need to be addressing them from the bottom up.
Absolutely, I completely agree. And I think to continue off of that, we have to look at policies at a local level. And one of the issues that we're seeing with COVID-19 is that at a local level, there's such disparate levels of responses with regards to COVID-19. And you can't have that in a pandemic. You can't have one place that is on level 1 lockdown, another place that's on level 3 lockdown. It just doesn't work. So one thing that would work is making sure there's communication across different, whether it's municipalities or however small you want to break down these local levels, to ensure that policies that are in place to protect the communities that live there are in alignment with each other and complement each other. And that those, as Dr. Rivera said, that as those communities are going, as the public health officials in those communities have the funding to implement these policies, because it does become quite difficult to tell people to, wear masks when you don't have the funding capabilities to provide people with masks. There are a lot of people who are unable to obtain masks, or there are a lot of people who are, or to tell people to stay 6 feet away from each other, or don't go to restaurants and all of these things. You can't have that and at the same time not have maybe a package to ensure that people can do these things safely. If someone is going into work, like you mentioned, people, like a majority of workers going in right now, there's a plethora of Latinx community members who are going in to work right now, right? And they're unable to stay 6 feet away from each other. Like, I don't know how you do that in a big commercial kitchen, while working at a restaurant or doing all of these things. But we need to make sure that our policies that are going into place are complementary of each other, not just within the public health space, but within the labor space, within the housing space, within all of these areas as well. Because one thing I'm hoping that everyone is getting and learning during this COVID-19 pandemic is that public health is in everything that we do. It doesn't just work in a silo. So we can't just have physicians and experts coming in and saying, these are the things we need to do, let's implement this, if we don't have any buy-in from other areas of local, state, or federal level government. Sitting on a public health perspective, that's what I think about with regards to policies. And with regards to social media, I'm not a social media expert as much as, I know how to retweet something and that's probably it. But regulation is so important. And I don't know how, I have no idea how that would work, but finding out a way on a federal level to, check something for as disinformation or misinformation. I know there's certain social media companies that have started labeling the sources of different information so that people can have an idea at least of where this information is coming from and whether it's skewed politically or where it's coming from, like NIH or CDC, which is helpful, I think, in showing people these are coming from reputable services. The other thing with social media is, I think there does need to be public health officials, and this isn't policy per se, but public health officials need to know how to use social media. Public health people, physicians, researchers need to understand how to leverage social media in a way that as a tool of health communication. So I don't know if that would be a policy level through the education route and making sure that health communication is a required course for physicians and researchers and public health professionals coming through, because working in this field, I know a lot of people who do not know how to use any of these resources, yet do such amazing work that would have such a large impact on the communities that they serve. So I think maybe on an education level, that would be a policy that could go into place to strengthen how we communicate with people outside of the public health field.
All right, Thomas Smiley, you have your hand up.
Yes, thank you. I have been working with One Day Sooner in regards to human challenge trials and how that all is affecting people of color. There is a very distinct debate about, is it valid to include people of color in challenge trials because of the optics of it. The recent trial that they're going to have in the UK, there's a quote that says, there is some very clear data from around the world that BAME people, Black, Asian, minority people may be at higher risk of severe disease and severe outcomes. With that in mind, is there any need or is there any priority to either protect people of color or to allow people of color to be more included or give them a higher priority to be included in something like a challenge trial?
I can take a stab at this. I'm not, I don't work in clinical trials, but I absolutely think there should be greater efforts to include minority populations, marginalized populations in clinical trials or human challenges trials, because as we mentioned, COVID-19 has a much more disproportionate impact on these communities. And what we've learned with other through other clinical trials for influenza and other places is a lot of populations don't get included in these clinical trials. And what we end up finding out is that these vaccines tend to have different impacts on them. So one thing in the United States that I was recently reading about was a big concern is with regards to obesity and the inflammation associated with obesity and the impact that would have on the COVID-19 vaccine. And the impact it would have is that it would be less effective in people with obesity who experience inflammation. In the United States, African-American women, African-Americans tend to have the highest rates of obesity within their communities. So we wouldn't be able to understand how these vaccinations impact these specific populations, especially for an issue that specifically impacts one minority population if they aren't included within vaccination trials. So what that would take would be, there'd have to be a huge reconciliation with the past, with the medical past and the public health past, and relationships between African-American population and these major institutions. And we'd have to rebuild those communications intentionally within those communities to ensure that they feel safe and they know that they're going into this with a positive outcome for the community that they're with and for themselves and for the greater population at a large. I don't think we can have we can include these populations in these trials without acknowledging the great hurt that we as public health professionals and as medical people have imparted on these populations. But yes, I think there should be a very specific focus on trying to recruit more African Americans, Asian Americans, Latinx Americans into these trials. I'm not sure if I'm not a clinical trials person, but I don't know, I can see like a couple of nods from the other panelists, so I'm hoping I'm going in the right direction.
Yeah. Go ahead, Chioma.
Yeah, I just have a couple of thoughts about that because challenge trials and clinical trials operate differently. And I think in this moment where people are talking about them simultaneously, especially if you're not, like challenge trials are something that I recently became familiar with. I think people are more familiar with the idea of a clinical trial, things that take longer, there's more rigor involved. And of course, we certainly want more representation from members from marginalized groups to participate in these types of trials. But my understanding of challenge trials is that there's more risk associated with them compared to clinical trials. So as much as we want to encourage people volunteering for the purpose of science, and because they're the demographics that are suffering disproportionate harms at least in this context, making sure people know the difference. Also talking about the benefits, the trade-offs, because there's a lot. I think the idea of challenge trials are kind of hotly contested, especially now, as Operation Warp Speed is putting in money into like fast tracking vaccinations from these pharmaceutical companies. So there's discourse around whether or not challenge trials are needed at this moment when the pharma companies are already kind of like moving more quickly than normal to get a safe vaccine out there. So I think just my point is just to emphasize the difference between how these things work. Maybe there's someone else in the audience that knows better how challenge trials work in order to accurately inform people on what they would be participating in.
Yeah, challenge trials are sort of our raison d'etre. That's what we're founded to advocate for. This is an expansion in a different direction, or an expansion. So I'm going to sneak in the last question myself, and I'm wondering if any of you guys can speak to the differences between different social media platforms. So I know, Yonaira, you mentioned WhatsApp, and Keona, I'm also sort of curious if you want to talk about Instagram at all, and any of you can, because it seems like there's less research and less data collection done around Instagram. But that is a way, obviously it's a really big way in which people communicate, in which people receive information, but it doesn't seem like, there's as much intentional health communication around that platform. So if any of you guys want to take a stab at that as our last question.
Absolutely, I will start. So I use Instagram primarily for my regular communication, but then also health communication. So I can briefly run through some of the social media platforms, and then the other panelists can jump in. I will admit I am like a horrible Gen Zer. I don't know how it all works. And so you have like Instagram, where you're able to communicate more through pictures and messaging. So this allows people to really put text in. Like I've read what I would consider summaries of entire dissertations in about 8 slides that you flip through on Instagram. Twitter has a 140 character limit, so people tend to talk more on Twitter, and it also can get really academic there really quickly, in my opinion. Facebook, I think we're all kind of familiar with how Facebook operates. Then there's also TikTok, which is primarily communicating through videos. Some people count Pinterest as a form of social media, which is mostly pictures. And then you can also think maybe about Reddit as another form of social media communication. So with Instagram, I also do this initiative that I kind of paused, but I'm hoping to get back into, where I and try to embark on wide scale moral education, and just to see where people are at through Instagram by doing what I call ethics questions of the day. So Instagram allows you to be very interactive, where people can use polls and they can vote, they can ask questions, they can literally respond to your question and ask another question. And so I would use Instagram and I would get about 500 users engaging with me, people who I did not know. And they would answer these questions about what is right, what is just. And it would be, I mean, about things related to distributive justice. What do we owe to our fellow human beings? So I think that there's a huge potential. I think we've talked a lot about social media for data collection, but I think there's also this huge potential for social media to be a tool to engage people in thinking about health and bringing it to the forefront of people's minds in a way that people just want to engage with and think it's fun.
Yeah, so I guess what I would add, without going into way too much detail about different platforms, different audiences are on different social media platforms for different reasons. I think that's the best way to kind of summarize it. When we think of a platform that Keona didn't mention that I want to highlight is WhatsApp. WhatsApp is very interesting. It's very unique. It's not that popular in the US and generally speaking in comparison to others, but it is a huge platform in a lot of other countries, including Latin American countries. So by proxy, a lot of Latinos use WhatsApp as a way to keep in touch with their family back at home. And there are countries where that and Facebook are the sole source of information because they're included in cell phone plans. Right? So when people access the internet, they access it through Facebook, or they have unlimited WhatsApp data plans included. So that becomes their primary source of information. So it's not that the platform per se is like the outlet, but it's where people are using, or what people are using to communicate. With WhatsApp, it's problematic because when we think about communities where trust is between these interpersonal family relationships, there isn't a way for us to be collecting data from WhatsApp because it is encrypted end to end. We can't just pull data or scrape data the way that sometimes some research is done on platforms like Instagram, etc. So we need to think about other ways to understand the role that those platforms have and how to reach audiences that use those platforms predominantly to help curtail misinformation about different types of platforms. Now, in terms of Instagram, one thing that I wanted to highlight, and I don't think that this is unique to Instagram, but in the context of Instagram, it's very important. These platforms that are very visual are also places for community. So a lot of people, and I'll give an example of breast cancer survivors or previvors that are going through mastectomies or are considering mastectomies, there are particular hashtags that become a community. And definitely we need to do a better job at understanding how to communicate with audiences there. Johns Hopkins actually has a fantastic Instagram COVID campaign that's going every day. So if you guys want to see a really good job at how to develop health communication related to COVID and vaccines, etc., follow their page because they really have done an excellent job. But at the end of the day, they're platforms that we can use as ways to mobilize communities. We've seen political mobilization from grassroots efforts across the world in different ways through these platforms. So we need to do a better job of not just using them, as Keona was saying, to research and recruit people, but actually promote our initiatives and educate in that capacity.
Anybody else want a last thought on that topic? All right, well, thank you so much to the panelists, and thank you to Stronger for co-hosting. Their website is stronger.org. Twitter is stronger_org. You can find them online, and you can find us online too. And again, thank you guys so much for being here. And thank you all for attending as well.
Thank you for having us.
Thank you.
Thank you, everyone.
Thanks, everyone.